Good evening, everyone. Welcome to the first live webinar of our extended family of practicing doctors, undergraduate, postgraduate students of medical and paramedical fields and all other subjects. So topic for today, mucormycosis, the black fear. The fear which is flourishing in our mind since a couple of few weeks, and every one of us, starting from a doctor to everyone, is utterly confused because of the various posts and social medias that's going on. So I'm not going into the technical details because we have an expert here for that. So not wasting a second, let us welcome the speaker for today, our chief guest, Dr. SAIKAT Saha sir, who will lead the session and will lead you to the details. Up to you, sir.
Thank you, Sayantan, for handing me over this and giving me the opportunity to share very, very predominant now. Now, whole country, right? Our country, India, not only our country, all over the world, people are concerned about the black fungus, and this has become a new epidemic.
Yes.
So, this presentation is actually a mixed presentation for the medical professionals and also for the laymen, the general common people who are already seeing this particular program, so that it is convenient for them too. So I'll be putting up the presentation.
Yes, sir. We can start.
I hope this is visible to everybody of you.
Just guys, so those who are participating, kindly write in the comment section if the PPT is visible to all and the voice is clear. Yes, sir, the answers are coming. It's fine.
Sayantan, I would like to you to giving certain responses from all the viewers. If they are asking any question, if they should type it at least, and so you could narrate so that I'll be able to find a track of those people who are actually really interested into it.
Yes, sir, certainly.
The first question goes to everybody. Let's start. The first question goes to everybody. What is fungus? Is it a plant? Is it an animal? What it is?
So, what sir is asking? Is it audible to everyone? Kindly just write the answer in the comment section, so that the answers are coming. Kingdom funky. No, don't go into that biological details. Just give us an answer whether it's a plant or whether it's an animal. Okay, sir, the answers are coming. That some are telling yes, some are telling none. Plants, some are telling plants, some are telling none.
Okay. How many you think the majority is saying about animal?
No, sir. Till now, yes, one answer is coming. It's intermediate.
It's intermediate. The person who has given that answer is the right answer. Yes, that was a wonderful answer by him.
Yes, sir.
This actually belongs to a different kingdom. The kingdom itself is fungus. Initially, there was a debate what it is. Since actually I'm not a biology teacher, or not a specifically a plant biologist or a zoologist, but still the thing is, things are quite clear that this particular species actually belongs to a kingdom. There is a kingdom called fungus. Itself is a kingdom. It has been nomenclatured. So we'll start with the black fungus, which is definitely a misnomer, thing which media has termed it, and maybe I really don't know why they have termed it. The first thing that comes into the mind, if it is the coloration of the skin in a blackish color, probably out of that, they gave a term. That's it. Then some terms they actually develop from colloquial words, and colloquially it comes. So it might have come in that way.
Yes, sir.
I'm not very much pretty sure. One assumption I'm making in that way. So actually, it's a particular fungus that's called mucormycosis, and mucormycosis is actually a species. It belongs to MUCORMYCOSIS species. As you can see in the electron microscope diagram, it's quite clear. So what it does, and where is it found, and how does it affect us? The first thing that affects us is through the airway. The airway.
Yes.
The first part of the airway is the nose, the sinuses. We have the maxillary sinuses, we have the frontal sinuses, we have the ethmoidal sinuses. So that is the main area in which these fungus, they try to enter and try to build up a colony into those areas. And second in the order comes the lungs, which is also a very good place for them to form their colony. And sometimes they take the entry into the body through some traumatic or breach in skin wounds. Well, there are other entry mechanisms, there are other places the fungus can settle in, like it can settle in any part of the, in other organs like liver, spleen, kidney, anywhere, etc. Obviously in the brain. So this is quite virulent, right?
Yes, sir.
Before we go into what it is and why, what it is not, we must know how many types are there based on the clinical findings, especially based on the areas they actually invade. And we have certain species. This is a species for those who are interested in microbiology. Rhizopus species is very common. Rhizomucous species, mucous species, and all these species are part of the mucormycosis. So if I say these species of this sort, so they come from which class? Anybody?
Anybody from the comment section? Students and all other those who are present, please respond. If you know the answer, kindly write in the comment box.
I started with that terminology from the start of the presentation. I go back. There it is. This is the term. They're from the mucormycosis and its succeeding species that we saw.
Yes, sir. The answers
So
are
you have
coming.
to remember at two or three of them are very important. Rhizopus, mucor species,
Yes, sir.
rhizomucous species. These are there are various type of mucormycosis
Yes, sir.
species. So, not going to very much into the biology of the microbiology of that, on the naming nomenclatures, we come to the symptoms that this particular disease they produce. There are 5 types, as you can see. The first is the rhinocerebral or the sinus, the brain type. That means this is the area that this particular fungus affects. So let's see what is rhinocerebral and the mucormycosis. Obviously, by the name, it means that it has to go through the sinuses. From the sinuses, it spreads upwards and it reaches the brain. And once it reaches the brain, the situation becomes very dangerous. It can also invade the orbit, the eye. This is a very potential area that these fungus, these infections, they colonize from the sinus, and they start actually from the nasal area, the nose area. There's a bridge area. Next, we know that next is the type is called the pulmonary types or the pulmonary mucormycosis, and obviously by its name we can make it out that these infections are localized into the lungs. Another type is the cutaneous mucormycosis. This mucormycosis happens by the breach of the skin. In any way, if the skin is breached and the fungus and that area is exposed to the fungus, there is a chance of its colonization into that area. Another very potential space is the gastrointestinal mucormycosis, which happens in the gastrointestinal tract, but usually it happens in children, in infants less than 1 month. They are very much susceptible. Actually, they are immunocompromised, and especially in those children who had to have antibiotics during their first month or need any surgeries. These children actually need this land up with gastrointestinal mucormycosis. Last and the most dangerous, the disseminated mucormycosis. What does it mean? This is mucormycosis that has become malignant, that has started to spread. That is, suppose a person who has a rhinocerebral mucormycosis, and it will spread to the lungs, and it will become a pulmonary mucormycosis. So one area to other area, it keeps on spreading, and that is really very lethal. So these are the 5 types. I hope you can recollect that, you can appreciate that. It is rhinocerebral mucormycosis, pulmonary mucormycosis. These are 2 primary things, because we are actually having this seminar since we are into a crisis in which we are getting to see most of the rhinocerebral mucormycosis and pulmonary mycosis in the country. Other 3 types are also prevalent, but not very much important in today's context. Now the question is, what are the symptoms? In case of rhinocerebral mucormycosis, or in any case, in any other mucormycosis, as we have seen that we have classified based on the location of these particular mucormycosis. So based on the location, based on the body part that is being affected, those will show the signs. So obviously, if it is affecting the sinus and the brain, so there can be swelling on the face, which is quite a normal, common thing to happen. There can be headache, because it sits in the sinus and it creates lots of headache issues. Nasal or sinus congestion might be there, and as I said before, there's the blackish thing in the nose. It starts from the bridge, or it can also start from the alar region, and there can be associated fever. What I am telling you right now is the basic general overview of mucormycosis. I have kept COVID-19 out of this scenario. In general, what is mucormycosis? Next, we have the pulmonary one. Obviously, most of the things will be common to other features, like fever is a very common feature, and obviously there is an infection, means we have in the chest chances of cough, chest pain, with shortness of breath. These are the particular basic symptoms which will be you'll get to see.
Yes.
So it is a very organ specific symptom, right? Now, when the skin is breached, so obviously what happens, there will find blisters or ulcers are there, and there will be blackening of that area, there will be pain, the area can be warm, anything that defines an inflammation, rubor, tumor, color, dollar, all those signs will be visible into that area, that local area. Now, in case of GI mucormycosis, since it's affecting the GI, obviously we'll having abdominal pain, there will be nausea, vomiting, and GI bleeding can be a sequelae. And now the most dangerous part, the disseminated mucormycosis. It's basically happens to who are very sick people. Already they have contracted mucormycosis, and somehow the immune system is very, very much low, or they are very, very immunocompetent. In those cases, this colony of fungus, mucormycosis, they will transport from one part of the body to the other part of the body. Classic clinical sign of mucormycosis. It's rapid growth. It's a rapid onset of the tissue necrosis, you see, and it is usually without a fever. Fever can come after on a later time. And why we have the necrosis? The necrosis because this fungus has a propensity to invade the blood vessels. As a result, they cause thrombosis, and due to the thrombosis, necrosis precipitates. Now, who are the people at risk and prevent, and what are the preventive measures? And who gets mucormycosis? What do you think?
Yes.
Any normal person will get a mucormycosis?
So the most common question at demand, everybody was asking previously, like can a normal human being who is not suffering from any kind of disease or who is non-COVID can get mucormycosis or not? So please write in the comment
That
section.
Yeah, that is that is a pertinent question. Now the question is, who gets mucormycosis? Healthy people?
Yes. So who actually get mucormycosis? Like healthy people? Like so the answers are coming only immunocompromised, people with low immunity, immunodeficient person.
That is right. That is absolutely correct. And those people who answered it, I really appreciate them. The thing is this mucormycosis or any fungal infection in our body is an opportunistic. These are opportunistic
Yes.
pathogens, right?
Yes. So answers are
They
also
they
coming.
in any normal person will not be affected by mucormycosis because the person's immunity is good enough to combat these particular dreaded species, right? So who are these persons? These persons are people with diabetes, especially people with DKs, cancers, people cancer people who have gone radiotherapy or who are already suffering from cancer, who have undergone chemotherapy, people with organ transplant, liver, kidney, whatever because they are on to immunosuppressant, stem
Yes.
cell transplant, and any transplant thing they will have. When there is neutropenia, why neutropenia is very is an indicator, because it is the first line of defense. Neutrophils, they come the primary particular line of defense. So if that is less, that cell count is less, then obviously there are chances of opportunistic infections like this mucormycosis. Long-term corticosteroid use, injection, and if someone is into injectable drugs habits, then there's iron overload. If some people who's iron overload or hemochromatosis, in those people, the chances of fungal infection of this mucormycosis increases, because if there's iron load due to the over iron, the red blood cells become siderized. As a result, these fungus, they take up those iron and they get more oxygen and they can flourish more. So that is the reason the iron overload causes the mucormycosis. Obviously, skin injury during surgery, burns and wound. In any surgery, burn and wound, obviously our immune system, our body is uh, already thrust into surgery, a burn, which is definitely a stress. In that stressful situation, when the wound is open, fungus gets inside our body. And obviously, in any cachexia of people or who have prematurity of birth or the low birth weight, these children are very much susceptible to mucormycosis. Now, how does someone get mucormycosis? You're walking on the street, and suddenly mucormycosis enters your nose. Does it happen? You're playing. You're into a gymnasium. You're doing a gym, and in the meantime you happen to contract mucormycosis. Does it happen? Fungus is everywhere. Spores are everywhere. Right now I'm talking to you. It's on my clothes. It's on the computer or the laptop that I'm using. It's everywhere. It's in the air. It's in the soil. It's everywhere. So, mucormycosis or any fungus, they are flying, or they're actually settled in certain objects. Like most of the objects, everywhere we have fungus, and it can come to us from any source. So, is it possible for us to stop breathing, close our mouth, nose, and everything, seal us? That's not possible practically. So. So we know, as you can see, when you're inhaling, the spores are getting to your body. When you're having a cut or any kind of injury, these spores, they enter our body. So it is practically impossible to stop these particular menace pathogens entering our body. So of the first question that will come in your mind is it contagious? No, it does not transmit from one person to other person. It doesn't happen. So it is not very contagious. Only thing that it is going to affect those people who are immunocompromised and somehow come in contact with this fungus from any source. So the question is, how can I lower the risk of mucormycosis? First, we can stop breathing. That's not possible. So since it comes from the environment, and so we have to have some control over the environment that will solve the problem to some extent, may not be 100%, as because we know there is no vaccines still to develop for mucormycosis. So let's see how we can prevent mucormycosis for immunocompromised patients. Some people, if you have patients or if you have known people who are immunocompromised, so what are the ways you can prevent these people? They can prevent it. So that all these are not established things. This is some guidelines which has been proposed by CDC, and they are not definite, but there is a thought that it might prevent the spread of the disease, or it can prevent the contraction of the disease from the environment. That is, suppose a person is working suppose a person, immunocompromised person, he's an engineer, or probably he's working in some kind of construction evacuation site. All he can do is to wear a proper N95 respirator mask. That actually prevent its entry. This is one way we can, because if you're considering that it has to be, it has to go through the airway system, so that will be prevented. Another way, to avoid areas in which there are moist areas. For example, after a flood, or after rainfall, or it can be some natural disaster, hurricanes, whatever. Everything becomes humid, and there is water clogging areas. The areas is very dirty, and this humidity score is very much important, because in very high humid areas, in very high humid rooms or environment, chances of mucormycosis increases. So people who are immunocompromised should always stay in a very airy and well ventilated rooms and areas, and the moisture should be under control. So, and these people should also avoid contact with soil, dust, as Yado, that regarding the people who are into gardening or farming, these people should avoid these kind of activities. And they should actually try to cover their body as much as possible with clothes, so that these things should not come and precipitate on their body. So these clothes will act as a barrier. So these are the quite common sense, and I hope you can think of many such things in which a person, any immunocompromised patient, can be prevented. Now, some people, suppose a person who has got kidney transplant or liver transplant, or these people, they are sometimes given antifungal medications. And why these antifungal medications are given? Because since their immunity is compromised, so that is the reason they already have a tendency to contract fungal diseases. So in order to prevent that, antifungal medications are given prophylactically to prevent these people from the disease. But it is always very important to tell all those people who are non-medical, please never try to self-medicate yourself. It can be dangerous. You can land up in a big problem. So always consult your doctor before taking any medicine, especially during these times. Not only, okay, fine, later on you can take, but during this time, so because we are in a COVID era, and we need to be very careful, and we should not do anything careless, so that we land up into a trouble. Question is how it is diagnosed. Can anyone tell me what is the diagnosis procedure?
Anyone in the comment section, please?
Can you think of?
Yes, sir. The answers are coming: biopsy,
Okay.
PCR, CT scan,
Mm-hmm.
culture media.
Fine. Can anyone, Shantan, can you bring up the voice of any person who is willing to answer it?
Yes, sir. Those who want to answer, just that single person, just turn on your mic and please respond. Just single person at a time. I repeat, just single person at a time. I think Joy Brotho, just turn on your mic and just answer.
Can do a swab and go for a KOH smear to go for microscopy.
Okay.
And sir, for see the extension of the mucormycosis, we can do CT scan. It has involved the bony structure, or for soft tissue, we can go for sir MRI.
Okay, that is a good thing. That's fine. That's actually the ICMR guidelines, and you've gone through it properly, and that's very good. Yes, but actually, what is the definitive diagnosis? Is definitely a swab test or a biopsy is the definitive diagnosis. It gives a definitive diagnosis. Thank you. What was your name?
Sir, Joy Brotho. Sure,
Joy
sir.
Brotho. Thank you very much. So it is diagnosed, as Joy Brotho has said, we have to diagnose this thing based on 4 parameters. That is medical history, the symptoms, the physical examinations. We have to clinically see the patient, and the laboratory test that will reveal it. So this is something which I want to tell you, that there is a histopathological evidence of positive culture from a specimen from the site. This is the de facto thing. This is the most important thing. We need a histopathological evidence, or we can do a culture. You know, the culture medium culture will always be a very good diagnostic thing. And also, we are doing the histological evidence. We might try to find the histological evidence from the localized area of the blackening or the infection, but it is always better to find sterile body sites. You know, because if we find this fungus into sterile areas of the body, it shows that how invasive the infection is as compared to foreign. That means there is a high chance that this infection is getting disseminated into other parts of the body. So that can be alarming. And in certain times where it can be very difficult to differentiate from other filamentous fungi in tissue. So this pathological estimation is sometimes very difficult when it is actually spreading to other areas. From a localized area, and you find another sample from a sterile area. Now it is very difficult to say find in specific patients. You know, patients who are already so much immunocompromised, they're having so a lot of problems. So you might be confused. Probably he might be having a headache. You actually don't know whether the headache is due to some cerebral condition he already he's already predisposed to, or is it due to the new fungal infection that is spreading to other part of the body. So in these cases, a good pathologist should be appointed in these cases. And I mean, the good pathologist means experienced pathologist. So, but unfortunately, there is no specific 100% diagnostic test. Okay, histopathological evidence is good enough, but recently DNA-based imaging techniques are being used. It's called MALDI, TOFMS. The full form of it is matrix assisted laser desorption isomerization, time of flight mass spectrometry, which is actually a spectrometry. So the advantage of this spectrometry is that it is very easy and it is cost effective. Easy in the sense it does not need a huge amount of manpower, so it is very cost effective. But the negative part is that there are many centers and areas in a country in which we cannot avail this particular testing facility. So, what is the treatment? Remember, I'm just talking in terms of generally what we are doing in case of mucormycosis cases, not in the COVID standard. For the COVID standard, I'll come later on into this discussion about what the ICMR guidelines are all about. So these are the therapeutic things mainly used in this diagnosis, in the treatment, sorry. So out of which, can anybody of you tell me the name of an oral amphotericin B?
Anyone in the comment section, please? Okay, those who are coming up with the questions, let me tell you, we will give you the slot. Okay, just wait. Okay, don't just, otherwise your questions will not never be solved. So please just wait. We will give you the slot when you will have the chance to have your questions. Okay, so please wait. So the answers are coming. Yes, sir.
Anything, anyone has given any patient amphotericin B or have seen anyone being given oral amphotericin B?
Anyone who want to answer?
What is the latest oral amphotericin B that has been proposed?
So answers are coming that amphotericin B is given IV.
Yeah, that is the right answer. That
yes.
I wanted to stress on the fact amphotericin B is not an oral formula, doesn't come into oral formulation. It has to come into intravenous formulations. And other two are posaconazole and isuvaconazole. These are also used, but right. So this is what I wanted to show you, that IV we have amphotericin B, posaconazole, and paroral we have only these two formulations, posaconazole, isuvaconazole. So this is all I have to tell you about this particular medications which are there. But the mainstay, since I am a surgeon, maxillofacial surgeon, I deal with the facial areas. So my main interest for treating these patients, if this they sit into that area of surgery or in that position of the things removed. That is, we need to debride that thing and we have to clear it as much as possible. We are not supposed to leave a trace of the tissue, but in certain situations, you have to leave certain traces of tissue. I'll give an example which happened in a couple of days back with one of my colleagues who is in Lucknow. So he was operating on a case with a rhinocerebral MUCORMYCOSIS. In that patient, when he started exploring the sinus tissue, he had to remove the orbit, he had to remove the sinus, and that infection reached the cribriform plate, and it was just about to touch the dura, and probably it touched the dura clinically, as he told me. So it touched it, and the patient's father happened to be a general surgeon. So when my colleague saw that that it has nearly reached the brain, so he went and told the patient's father that we might be leaving that area because that is brain and we don't want to touch it. Then what his father told? His father told him that please cut off that area of the brain that has been infected. That means his father was desperately trying to save his son, even if the son had to compromise certain other vital functions in his life. But his main goal was to keep his son alive, because remember, once it penetrates the brain, it's gone. It becomes a very difficult situation. But anyway, my colleague took the decision that he will not tease that area of brain, and he left it alone, and so he has kept the patient in amphotericin B with the high loading doses. And he is hopeful that that patient might recover, and let's see, keeping our fingers crossed, what will happen, time will tell us. Some people are given voriconazole for various other fungal diseases, but there is an evidence to suggest that pre-exposure to voriconazole, actually it increases the incidence of mucormycosis in some patients. So people who are already into antifungal therapy are very much susceptible, and especially voriconazole, people who were already into voriconazole, they are more susceptible to mucormycosis. This is one treatment modality. Another treatment modality will be is to take care of the immune system. That means if the patient is being given steroid or some other or if the patient is given immunosuppressants, all those doses need to be adjusted, so that his immunity must come back to combat that acute crisis. Because mucormycosis will be an acute crisis in an immunocompromised patient, so that priority should be there. Another, which actually I don't have any experience, is the hyperbaric oxygen therapy, which has been told to be useful, but they are not certain. There are no certain evidence regarding that. But we can also think of. But it's beyond my scope, because actually I haven't seen a patient being treated in hyperbaric oxygen in none of my patients actually. Now we'll talk about a little bit incidence. When a person comes to you, when a patient comes to you with mucormycosis, so you have to know actually what is the chance of survival, or what is the mortality rate. It is near about 50%, as you can see. This is the percentage which has been given by CDC for the current update, and the mortality rate of the person, varies. They have reviewed many articles. They found that this is the basic 54%, and they also found that the mortality rate varied, due to the three important factors. One is underlying patient condition. Second is the what type of fungus has penetrated in, and the last and the most important is the what area of the body which has been affected. Now you can see 46% is into the sinus infection areas, and 76% pulmonary infection areas, and 96% for the disseminated mucormycosis. We can, as I told you, why I told you that disseminated mucormycosis is very dangerous, because one area spreading to another area becomes a tough job, right? And this is exactly happened. We can see this thing into this 96% for the disseminated mucormycosis. Whereas the sinus infections are concerned, that is as 46%, much better as compared to disseminated ones and pulmonary infection ones. So in case if you find patients with rhinocerebral mucormycosis, always take prompt decision, because there are high chances that you might win the battle, or the patient might win the battle, because we see at 46%. But in a disseminated case of mucormycosis, the chances are very grim, but you should give it a try, right? So this is all of the presentation that I was trying to tell you. But right now I'm going to talk about mucormycosis in respect to COVID patient. The very first question, a very common question which has been asked to me by a lot of people, lot of common people, even the students who are asking, why during this time are we into a black fungus, epidemic? Well, it's an epidemic because of the COVID epidemic. Why? Black fungus was always a disease. It is nothing new. It is nothing that it happened just now. Our whole country, or rather the whole world, has been affected by COVID. Our whole community, the immunity has come down. Suppose, let us talk about before 2020, suppose 2019, 2017, whichever year. In a normal situation, the number of immunocompromised people in India, say, was maybe 2 to 3% of the population. And out of these immunocompromised patients, only certain amount of people, they contracted mucormycosis or black fungus. So, if I think that India is 130 crore people, and at least 50 lakhs are, at least 2 lakhs are immunocompromised people, and out of that, only 500 are land up with this kind of situation. But right now, right now, the number of people or number of immunocompromised patients has risen due to the COVID, because COVID has affected every person's immunity, the immunological status. So now the number of incidents of immunocompromised patients have increased, and so henceforth the number of black fungus or the mucormycosis cases will automatically increase. So if we go by the media statistics that so many people have been affected and so many people are into a deep state, so it is just because the whole community has been affected, and so the as based on that percentage is still the same or near about same, but the numbers and the figures look big. So that is the reason we are having this kind of epidemic. That is the reason we are seeing this as an epidemic, because overall the community's immunity has come down. All people immunocompromised. Usually, as you can see, that what they have said, that the time of presentation in case of COVID is 3 weeks of onset from the COVID symptoms of COVID-19. It comes with 3 weeks onset from the symptoms. Usually, it can happen any time. It may be after 5 weeks, but usually this is the area. And why? Why will it increase? Because due to the stress, that people who are already diabetic, that the hyperglycemic, their control will be quite difficult, and so the prevalence is in India. And as you know, Indians we have quite a higher incidence of diabetic people. Uncontrolled diabetic people, and this is the reason that we are having this kind of epidemic. And rampant overuse of steroids. I've seen patients taking steroids. They go to the shop, they read from internet, they know that then someone needs prednisolone, someone needs dexamethasone, and they start using steroids in order to, because they were scared this COVID is going to kill them, and so out of that fear they start doing this. But this can be very dangerous. So all those people who are non-medical and are into this seminar, please do not avoid all these kind of activities, and also please tell anyone you know not to do this kind of thing. It can be very dangerous. So the steroid overuse should be stopped, and don't self-medicate. And in the ICU and the people, and this COVID people who are in ICU, they're very highly susceptible, because nosocomial infection, broad spectrum antibiotics are given, and overall the immunity, most of the immunity of the person literally goes down. Now there can be other malignancies like hematological malignancy, because in hematological malignancy much of the cell count goes down. And in organ transplant, we also organ transplant people, because number of people, there are so many people who are getting organ transplant, and some, as I told you, voriconazole is being used very permanently in very many areas of people who have received organ transplant with the anticipation that they might get mucormycosis or any other fungal disease, and they are given prophylactically. These patients are given prophylactically voriconazole, but as I told you, as CDC has mentioned, this has shown that it increases the chances of mucormycosis. Now, the mucormycosis, the signs and symptoms, as I discussed, but we'll discuss a little bit in detail. There will be, in case of the face, not only it affects the sinus, it affects the jaws, it affects the gums areas, any oral cavity, and it can affect anywhere in the oral cavity also, and also the orbit. So anything that those areas which have been affected will have pain, swelling. These are the common things. And when a local area has been affected, there can be paresthesia, because we decrease sensation of the face. And the coloration of the skin will change, especially over the nasolabial groove, and alar-nasal, that is the alar region of the nose, that is side of the nose. We can see the alar cartilage. That region, the particular blackishness starts, and we can see blackish nasal discharge also in some people. And there is nasal crusting. There's a crusting area in the nose, and like clotted black sort of thing might come. And Over here, there's a thing called conjunctival infection of chemosis. You can see the redness of the eye. We can see the swelling, periorbital swelling will be there. There is diplopia, blurring vision. In ophthalmologist need, needs to be consulted as soon as possible when these kind of blurring takes place, or there is a periorbital swelling when you cannot discern any other pathology. And since it is an epidemic, you have to act prompt. So don't be very lazy. There can be loosening, and dentists who are there, you can see the loosening of teeth. Nowadays, if you see anything, any person's teeth loosening. So you always keep that in mind. Not every patient who comes with a grade 3 mobility and you start thinking, oh my God, he's got mucormycosis. No. The first history is very important. You have to take a proper history of the patient, whether due to some reason he had certain history of anything like COVID-19 or any other immunocompromised states. So based on that, make your diagnosis. Then you can see the palate. They can be see a large blackish kind of mass or a discoloration, and that gangrenous things are there. And inside the nose, if you go for endoscopy of the nose, you can see inferior turbinates will be gangrenous, will be blackish in color. And there can be hemoptysis, chest pain, alteration of consciousness, and headache. Why alteration of consciousness? It might indicate that it has entered the brain. A headache also a good indicator of that it's entered the brain. And headache not always an indicator that it has entered the brain. It can be due to the areas that it is affected, like the sinuses. If the thing has happened, if there is a collection in the frontal sinus or the maxillary sinus, what happens? The person complains of pain and headache. Now, the investigations the ICMR has advised is NCCT, the non-contrast CT of the PNS. Why? We don't need a contrast CT of the PNS. We need a non-contrast CT of the PNS only to see what are the bony erosions that are taking place. How is the ethmoidal sinus area? How are the turbinates doing? How are the sphenoidal sinus areas? So, in order to check that, you have to do a non-contrast CT PNS. And HRCT chest, as the gentleman told me, that is a very good option. Also, you have to go for a HRCT test to find whether there are any halo signs, bronchus signs. There are a lot of chest signs are present. That is beyond the scope of this discussion. So we need to see lots of nodules. There might be so many big nodules. And we can go for a CT angiography. Why angiography? Because this mucormycosis, this fungus has its primary target as what?
Anyone in the comment section?
What is the primary target areas? Anyone, Sayantan?
Yes, sir. The answers are coming. Blood vessels.
Yeah, that is the right answer. Who was the first person who answered it?
Shubham Nandi.
Thank you, Shubham, for the wonderful answer and very prompt answer, because you answered it very fast. Yes, actually, I told you before that this particular fungus tries to go and invade the blood vessels, and so CT angiography is a good option because through that you can actually trace the areas in which this fungus is actually localizing. Okay, MRI brain and better delineation of CNS involvement can be found through the MRI, and so these are the three investigations you are going to avoid: radiological investigation. One is the PNS, NCCT, HRCT chest, and MRI brain for the diagnosis, to find diagnosis and the spread of the disease. And the final diagnosis, which is I'm saying KOH staining microscopy. What is the percentage of KOH in KOH staining?
Anyone? Please write in the comment box.
This is just a revision class for something which most of you have studied.
I think the second year might give the answer. So answers are
Now,
coming 10 to 20%. 10%, 10 to
10 to
20%.
20%. 10 to 20%. It's usually 3% KOH staining. Anyone said with 3%?
No, sir, no one.
No one. Everyone is in favor of 10 to 20%.
Yes, sir.
So anyone who's going to challenge my decision,
Anyone?
he or she can.
Anyone want to add something? You can write in the comment section.
If you have any specific reason to say about 10% or 20%, whatever percentage you are giving, can you give a substantial answer to justify your point? Because this is a revision class.
Those who have given the answer, please respond. The reason why you have written 10 to 20% or 10%. So.
Okay, anyway, fine. Everyone has started. Well, it's actually the what we the test is all about, the stinginess, KOH stinginess. But you know what is KOH stinginess? What happens in a KOH? It actually delineates between the gram-positive and the gram-negative species. The KOH, cannot invade the gram-positive bacteria fungi, but they can invade gram-negative bacteria. Why? Because the cell wall of gram-negative bacteria is quite thin, and this KOH, they can go inside the particular cell and disrupt the cytoplasm, and as a result, the DNA comes out, and when the DNA is thrown out, it becomes sticky, and it comes in a stingy. Have you seen a glue? If you put a glue in your hand, in your finger, between two fingers, and you try to stretch your fingers, the whole thing is being thick and so stingy. So that is also called KOH stingy microscopy. So another thing is, as I told you, was Maldi Toff. That is quite difficult to pronounce, right? To remember. But anyway, whatever it is, you have to remember it's a spectrometry. This is quite a handy tool, and it is used to diagnose, a lot of things, like how a new species has, if a new species has come, they also try to find whether it's a biological warfare weapon. So they also want, it is also used to find out any epidemic or pandemic which is happening. So all these pathogens can be found out by this spectrometry very easily. So, and microscopically, if the examination is done, you have to find the hyphae 5 to 515 micro size, and the branches should be as right angle. Now we come into treatment. So see, actually I'm trying to discuss the guidelines given directly by the ICMR, and that this is very important. So I'll just have a revision exactly what we learned about the. First is, what is the reason that there's an increase in mucormycosis? We have 6 points. Hyperglycemia, rampant overuse of or irrational use of steroids, and onset of diabetes due to steroid overuse. This prolonged ICU stay. If there are pre-existing comorbidities like malignancies or immunosuppressants, and if certain patients are on to voriconazole as antifungal prophylactic drug, and these people are very much susceptible to it. And as I said, signs and symptoms depends on the area that it is. Since we are talking about oropharyngeal areas, so these areas, the facial pain and pain of the sinuses will be quite predominant. You can have certain discharges from the nose, certain crusting in the nose nasal areas. If it at all affects the eyes, the eyes, there will be periorbital edema. There will be ecchymosis of the conjunctiva. Okay, then there can be epiphora, there will be blood vision or diplopia, and from the oral side, from the dental side, there can loosening of the teeth. So any person who already has a periodontitis and come to you for some opinion, don't straight away jump and decide that that the person is suffering from mucormycosis. You must take proper history, and the history will give you a clue that the person had some kind of immunocompromised state. And be alarmed, especially when there are respiratory symptoms. If there is hemoptysis, chest pain, these are the common findings. Investigation, 3 investigations I told you: NCCT, PNS, HRCT chest, and MRI brain. You can also go for CT angiography. Diagnosis, nothing is confirmatory, but based on the clinical scenario, this situation, the KOH staining, little can be used, or if you histopathology for microscopic way, you can find out aspect hyphae, which actually should be at right angles, and you have the size that the histopathologist has to find out from there. And based on the clinical scenario, you has also come, and based on the CT findings, you have to come to a conclusion. So when do we have an index of suspicion? As I told you, any person comes with a loosened tooth and you just jump to a conclusion that a person is having a mucormycosis, but that will not be anything, any suspicious thing, like if there is anything very relevant in the history. So all the necessary tests and everything should be done timely, and that is very important. A multidisciplinary team is required, because you need a microbiologist, you need a general surgeon, you might need an ENT surgeon, you need a dentist, you need a plastic surgeon, you may need a pulmonologist, you might need a cardiothoracic surgeon, or you may a gastroenterologist. It can be so many specialities are working onto this. So what is the line of treatment that I mentioned? Is the amphotericin B should be the initial dose. Like that is, they said, as I told you, I mentioned liposomal amphotericin B is the initial dose. Remember this figure: 5 milligram per kg body weight. And in case of CNS, if there is a CNS involvement, you have to increase that to 10 milligram per kg body weight. This is very important. Can you see the marking that I have given?
Yes, sir. The markings are visible.
So remember, this amphotericin B comes in a 50 milligram vial, and you should dilute it. Don't give a concentrated solution. Don't inject directly. And if you think that due to some other reasons that amphotericin B cannot be given, in that case you can go for posaconazole. That is very important. Orally, if you're preferring that, or the patient's condition is that he or she cannot take amphotericin B, you can go for posaconazole 300 milligram delayed release tablet twice a day for 1 day, followed by 300 milligram daily. The first day should be 1 tablet twice a day for 1 day, and the followed will be 300 milligram per day, and continue the treatment as long as continue the medication as long as the symptoms and the signs fade out. And so isavuconazole is 200 milligram, 1 tablet 3 times a day for 2 days, followed by 200 milligrams daily can be done. So those who are first year, second year students, you need to write it down. It's very important. Posaconazole 300 milligram delayed release tablet twice a day for day 1. Then it should be followed by 300 milligram daily. Isavuconazole should be around 200 milligram 1 tablet TDS for 2 days, then 1 tablet OD till signs and symptoms resolve. Not only clinically, when I say resolve, it doesn't mean that only clinical, based on the clinical signs and symptoms. No, you have to also have resolving into that information should come from the radiological side, the radiological signs of the active disease and animation, and all these things should be negative. And you have to eliminate should be taken care of. And not only, and these hyperglycemic state or immunocompromised compromised state or immunosuppression state should be taken care of, and these things should be continued for a long period of time. Now, in case, if you are not, this is very important, in case, this is the ICMR has given a beautiful guideline to us, that in case liposomal amphotericin B is not available or deoxycholate 1 is available, then the dose is not 5 milligram and 10 milligram per kg as compared to lysosomal 1. It is 1 to 1.5 milligram per kg. Those who are students, you can write it down. And if you don't feel like writing it right now, you can download it from the MOHF. You can see this website. It's out here. You can see mohfw.gov.in. You can go to this website and download this document. So it's just a formal discussion that I'm having with you. This is the guideline, because understanding the guideline at this hour is very important. Now, very important, what are the do's and don'ts for the doctors? First important thing, use the steroid judiciously. This is very important. Rational use of antibiotics are very important. Now, you should be prompt in diagnosing the disease, and then initiation of amphotericin B is very important. That you should timely initiate that this drug. And also, hyperglycemia should be under control even after post-discharge. Patient should be monitored quite weekly, or maybe by a local doctor, maybe his house physician. He should be advised. Insulin should be used. And so, the areas which are very high risk factors, they got basically examined the eyes. So you have to regularly examine the eyes, nose, and the mouth for detecting signs. This is very so regular. Monitoring is very important. Even when the patient is in the ICU, when the patient is in a general ward, any COVID patient, his eye, nose, and mouth should be examined rather regularly. Another very important thing: use clean, sterile water for the humidifiers. Please. Those who are into their rounds, or those who will be into the rounds in future, always make sure and insist all the nursing staff to keep the humidifiers nice and clean. It should be washed regularly with soap, and the water should be sterile. The water that is given, because it has been seen that most of these infections, which are happening in the COVID patients in the hospital base, so they actually are due to these humidifiers. It has been found, because, for example, the patient is discharged, the next patient is given, the humidifier remains the same. So these humidifiers need to be cleaned properly every day. So it is quite obvious. Do never miss an early waiting sign. But remember, a person complains of blocked nose, and you think, oh my God, it might be even my season rhinitis sort of thing, and so you just ignore it. No, don't ignore it, because since it is a pandemic time, so you must be careful. Anyone complaining that you have a blocked nose, at least examine that person properly and keep that suspicion in hand. Also, definitely based on the history, the timing of treatment is very important. Now the question is, what you are going to tell the patients? Because I'm saying it's not a study, it's just the guidelines. So remember, you have to say these patients, these are very important. You have to tell them, their morbidities such as diabetes, hypertension, all these things have to be informed. You have to take the proper history, thorough history, and tell, because some of the patients never want to give any history properly. So you have to keep on poking them, you have to gently ask them that what any other relevant history. Try to take out history, because that is very important, crucial. And the patient should also, as we know, that is very important. And they must be always encouraged to use personal hygiene. Personal hygiene is very important. So in case they have a nasal discharge, or they have a black nose, or they have kind of discolored colored thing coming out from the nose, they should inform you. Any eye swelling, tell them that if you have any eye swelling and difficulty of vision like diplopia or blurred vision, always inform us. And this is very important. Another very, don't self-medicate, which is very important. As those who are already doctors, they already know this menace that they see to the patient. Most of the patients in India, sometimes they have a tendency to self-medicate, which can be dangerous. This is all about this. In a very nutshell, we talked about mucormycosis in general, what it is. And at last, we talked about what is the ICMR recommendation and guidelines. This is what, and I am revising again the ICMR thing, reasons. What are the reasons for the increase in mucormycosis? We know. And then we saw the signs and symptoms, facial pain from conjunctival infection, eyes, mouth, blurring vision, respiratory symptoms, we saw it. Then we saw the investigations, NCCT-PNS to see the bony erosion, HRCT chest, also CT angiography and MRI brain if there is a CNS involvement. And what are the lab diagnostic procedure? We send the sample, the local sample for K staining and microscopy. And also we can go send the debrided tissue. If you debride the area, we can send it for a tissue culture and microscopy. There's another thing we talked about in MALDI-TOF. It is spectrometry, DNA analysis. But there is not always available everywhere. Now another ribbons in this histopathology under the microscope, you got to see hyphae around 5 microns, which should branch at right angles to each other. Aseptate, it should be aseptate hyphae. This is very important. There should be aseptate hyphae, and they should be branching at right angles. And we saw the treatment modality. The treatment was liposomal amphotericin. Remember, first is liposomal amphotericin B. What is it? 5 mg per kg body weight, 10 mg in case of CNS involvement. So I mean 10 mg per kg body weight. And alternatively, if you don't get a liposomal amphotericin B, you get a conventional amphotericin B deoxycholate 1, and the dose is around here. I have to give this patient. We talked about posaconazole, which can, if given orally, it should be given this way. And isavuconazole, 200 mg tablet, 1 tablet thrice, 3 times a day for the first 2 days, followed by 1 tablet, 200 mg every day, till the symptoms and the radiological evidence is weighed off. Apart from that, the hyperglycemia and immunosuppression state should also be controlled, not only for a smaller period of time, but a longer period of time. So these are the guidelines you have to follow. It's quite simple, straight out of the box, and so that you can remember. Please try to remember this, and I hope people who have been affected will do better and come up well following these guidelines. And if you have any questions now, you can ask me.
Okay, so anyone having any questions, just turn off your mic. Just remember one by one, and just present your question, please.
Yeah.
Anyone having question, just turn on your mic and.
Hello, sir. Hello, sir. My name is Kovid Basu. So I have a question that is blackish discharge can also occur in mucormycosis in non-COVID patients?
Yes. Mucormycosis, any mucormycosis patient, any person with mucormycosis will have a blackish discharge. That's the reason they have been called the black fungus. Though that is not the name exactly, but since this black thing is coming out media or socially, this has been portrayed right now. So if that has been portrayed in that way, you can say black fungus. So it can happen with anyone. Only difference, both are same. Non-COVID scenarios in which who are immunocompromised and COVID scenarios who are immunocompromised. Both these situations are same. Only thing that in COVID patients, there the immunity, right now we are having a pandemic situation. Only thing that we have to understand that if okay, fine, the patient had a COVID and so he has a chance. So based on his complaints and history, you can find out he already had an immunocompromised state, and so it's quite natural to find mucormycosis. Not natural, but it's likely it can happen that you can see a black discharge from the nose. It doesn't matter whether it's COVID-19 patient or a non-COVID patient. Only thing that somehow there is a compromise in the immunity. That is important.
Sir,
is it clear?
Yes, sir. I have one more question, sir. Is the blackish discharge due to tissue necrosis or some other reason?
It is due to the tissue necrosis. I told you that this particular fungus has a direct effect on the blood vessels. They cause tissue necrosis. There is a clot formation, and this necrotic tissue becomes black. Hypoxic area. There becomes a hypoxic area. Any hypoxic area becomes necrotic, and that you have to go to the full pathophysiology of it. So, this discharge is black. Actually, it's actually the sinus fluid that comes out.
Okay.
The collection happens whether in the maxillary sinuses or maybe in the frontal sinuses. Any sinuses that it precipitates.
Anyone else?
Is it clear?
Yes, sir. I am clear, sir.
Okay. Anyone else?
Okay.
Anyone else want to ask something? Just.
I am Jayabruta Sarkar, sir. Sir, after the COVID, after resolution from the COVID, the patients are advised to take steam and gargle, sir. Sir, how this is this can be related to mucormycosis, sir?
Actually, there is no evidence because the concrete evidence regarding this. Even there are some researchers are saying even steam. They are saying that steam is not useful, beneficial in case of COVID. Some papers are publishing steam is causing aggravating cases of COVID infection. So there are lots of yes. So the only primary thing that the reason why we have mucormycosis is that there is whenever there is moisture, when the moisture contamination is very high, wherever there is moisture, fungus will always pull in. Is it clear?
Yes, sir. Yes, sir.
Want to ask something?
Sayantan, we have a question on chat box.
Okay, Anagh, just read out the question.
Yes, the question is by Sharadya Dasgupta that zinc is used in COVID treatment. Can it be a cause for mucormycosis? Should I repeat, sir?
Yes.
Zinc is used in COVID treatment. Can it be a cause for mucormycosis? Question has been asked by Sharadya Dasgupta.
Sayantan, can you come out? Actually, I can hear him properly.
Yes, sir. Yes, sir. Sir,
What can cause mucormycosis?
Yes, actually, sir, she is asking that since zinc is being used in COVID treatment, so can it be a cause for mucormycosis?
Yes. There have been findings that zinc is responsible for mucormycosis, but there is no concrete because there are lots of researches which are going on based on the current data, and it's very difficult to say. It's too early to comment on that.
Yes.
But there are evidences. I've gone through journals and I found that some articles they mention that zinc is contributing to mucormycosis. And because even the world doesn't know how much zinc to give in case of COVID patients, even because this is a very confusing scenario, because whole world actually doesn't have a concrete resolution. Everyone is trying. Researches are going. Clinical trials have been taken, and data are collected from various areas. And so it will be a good thing for every one of you to publish any little data that you get in articles. The more articles you publish, the more publications you do, the more better is for the fraternities, for humanity, for the world. Because in that way, the science grows better.
So, I think your doubt is solved. Just reply yes or no in the comment section, or you can just turn on your mic also. Okay, sir. Now the next question which is coming up, that in case of people wearing N95 masks, if already certain fungal spore of mucormycosis are present, as the mask is making the covered surface ideal for humid condition, will the fungus?
Absolutely correct.
Yes, sir.
Absolutely correct. This is a very good point which has been taken. It now, there have been sporadic incidents. It has been found the person never had COVID. He is not even immunocompromised. Still then, the person had mucormycosis. So what can be the reason? There is one theory. This is not a concrete theory. There is a theory behind it, that when we use, first of all, we are being using masks due to the COVID pandemic. Everyone is using. Some people are using cloth and they never wash it, and probably they are very much careless about it, keeping it clean. So what they do, they wear the mask, and they come back home, they hang it, the next day they wear it, and this way what happens, even there is bacteria inside your mouth, fungus inside your mouth, everywhere it's collecting. So they also keep on getting collected out there. Even that means even particles, even plaque particles, even vapors containing many bacteria or other debris, they get settled in the mask, and the mask becomes very unhygienic, and that area becomes the nidus for fungal growth, and that fungus will enter your mouth or enter your body, and that fungus makes your oral cavity very unhygienic, and all the bacterial endotoxins are released, and all the cell areas, the things are very much affected. Cellular mechanisms are very much badly affected. As a result, the fungus takes a growth. So this is a theory which has been proposed, and work is being now. People are now putting their heads into it to find out the exact reason.
Yes. So I think you got your answer, Rick. So don't use the masks for a long time, say 1 year. Then you can cope up with any bad situation, not only mucormycosis but anything else also. Okay.
Yeah, it's always a good habit,
Yes,
and you also
yes,
promote
yes.
not only yourself, other people to change their mask, to wash their mask on time. I've seen people using surgical masks day in day out without even washing.
Yes. Okay. So coming
So
up with the next question,
doing
sir.
things in a proper way is a very important thing.
Yes, sir. Okay, so now the next question which is coming is, the children are prone to infection to this disease.
Children are not prone. I again repeat, it should be very clear. People whose immunity is compromised, anyone whose immunity is compromised, the immune systems cannot combat the fungus, then only the fungus will become an opportunistic infection. Then only the fungus will get its entry. Children, as I said, especially it happens with the GI mucormycosis, the gastrointestinal mucormycosis, as I told you. Why? It happens with children who are given, or neonatal, less than 1 month of age, who need surgery due to some reason, or who might need antibiotics to certain conditions. If they have to give antibiotics, in those cases the immunity gets compromised, and as a result, those infants, they contract GI mucormycosis. But usually, if the child is healthy, they don't contract mucormycosis until unless their immunity is compromised. Only thing, immunity is the main power to prevent mucormycosis. If the patient's immunity is good enough, mucormycosis usually won't precipitate.
Okay, so the next question, sir, which is coming up. Okay, so they are asking that Auditro Bhattacharya. So he has asked the question that, is there any risk to recently vaccinated people contacting the fungi?
No. This has nothing to do with the vaccination. Vaccination has nothing to do with it. Vaccination it has its own process. It has nothing to do with the fungi.
Yes. Okay. I think Auditro, you got your answer?
Yes, sorry, sir.
Okay, fine. So the next question, if a non-COVID person once in a lifetime gone through steroid treatment can develop mucormycosis?
Yes. A non-COVID patient, any person who is having steroid for longer period of time, or maybe whatever the reason, whatever the medical conditions he has, they are very much susceptible, because what a steroid does, steroid always brings down the immunity. So when the steroid brings down the immunity, means these person, as I said, the one equation, it's a E is equal to mc square, like Einstein said about relativity. In this case, the equation is very clear. Any condition or any reason, the immunity comes down, fungal infection or mucormycosis precipitates. That is the, just keep that in mind. It's a straight little infection, the equation. So think of condition. If you think of any condition, any situation in which the person's immunity is down, it is down. That means he is susceptible. It doesn't mean he will have it, but he is susceptible. He becomes highly susceptible to this infection.
Okay, so the next question is gastrointestinal mucormycosis due to food.
It can also be, I said, any kind of entry into the system, but usually it doesn't happen that way. But only thing that I said, it can, the mucormycosis can occur any part and any organ of the body, internal organs of the body. All it needs is to take its penetration into the body, maybe through the GI tract, maybe through the blood vessels, maybe through a wound, external wound. Whichever way, if it takes an entry, the person's immunity should be down. If the person's immunological status is down, then he or she is going to have that.
Okay, so I think Ritam Shahu, you got your answer. Okay, the next.
No, if you have any doubt, if you think that the thing is not clear to you, then do let me know.
Yes, please write in the comment section, or if you have any doubt, just put your mic on and then ask the same. Okay. Okay, we can proceed. So the next question is coming from Sayantan Das. When a person recovers from mucormycosis, what are the chances of getting reinfection, and how the severity will vary?
Its severity varies upon what is the immune status. I told you that even after that everything is resolved, the patient should have his or her hyperglycemic status or immunocompromised status, or if he is taking into immunosuppressant drugs. All those things should be monitored regularly, because no sooner the infection, the immune status pulls down, the infection comes back. And how well it's going to hit that person, it depends what is the state of the immunity. If the immunity comes down, when immune compromised, these patients, this whole immunity comes down very much, depending on that, the intensity of it.
I think Sayantan, you got your answer. Okay, thank you. The next question is that nowadays everyone is taking vitamin tablets to increase the immune system. Is it good for health, or if it's, then how long we have to continue it?
Well, you cannot take vitamins like taking everyday meal. So there is a time limit, there is a threshold, and don't think the vitamins are the solution for immunity. First. Second, vitamins actually help in the metabolism. The body needs certain metabolism. The body needs to have certain chemical reactions. Body needs certain biochemical reactions which are going inside the body. For those things, vitamins are very essential. Maybe directly, maybe indirectly, but these are essential. So this is the way in which you actually provide that deficiency. But once the deficiency is over, there is no point in overloading in body with this. With anything you overload, it has its consequences in a bad way, not in a better way. So vitamins are not the only option for boosting your immunity, because there is no clear indications by any organizations to give vitamins to boost your immunity as a whole. It is thought to be, it is hypothesized to be, it is one of the tools, but it cannot be the tool to keep your immune system open. So you have to understand what immunity is. That is beyond the scope of this discussion. But if you can understand that, then you'll be able to understand that why vitamins or any other drugs or any other mechanism will improve your immunity. Nothing improves your immunity.
Yes.
There is certain genetic factors are also involved.
Yes. So I think
Basic constituent of your body or the gene, the inheritance that you get, and also the specific property of your body is also very important.
yes.
They play, that is the main role.
So I think Anagh, you got your answer. So yes, so that means don't medicate yourself with any drugs without a proper medical consent.
Don't overdose.
Yes.
Nothing over, nothing subdose. Suboptimal doses are also bad. Even giving doses beyond the limit or the timing is also bad.
Okay.
Please stick to drug regimen. And for all the students, go through the pharmacology books properly, learn the dosings properly, and please try to give even antibiotics, everything in the proper dose. Proper dosing is very important. Trust me, this is very important, and it works. Actually, you will be helping not only your patient, also your community if you are using for antibiotics. If you give proper dosing. Because I have seen people, I have seen very unfortunately, it's very unfortunate. Some people have seen they have been prescribed antibiotic irrationally with suppose they are given amoxicillin in a dose of 500 milligram too early, or even I have seen amoxicillin given in 500 milligram once a day for 5 days. So these kind of dosing should be avoided. It's a menace. It is a menace to the society. Anyone else?
Yes, sir. The next question is coming up. During this COVID pandemic, what precautions should a diabetic observe? What changes in their lifestyle stands protective for them?
First is diabetic people has to take control of the sugar. That's the prime thing. Second, they should they should have a very healthy lifestyle. They should not stay awake at night. They should have a very healthy lifestyle. They should not. They have to maintain their timings properly. They have to take their anti-diabetic medications properly. They have to take the insulin. If the patient is on insulin, the insulin should be taken properly. And regular checkup is very important with the physicians. This is very important. The only thing that they have to keep the sugar down, and they keep on just by seeing that the sugar level CBG report. The CBG, well, it gives you a track. That's good. I won't deny that. But HbA1c, 3-month scoring is also very important.
Yes. I think Sumit, is your answer clear? Just write in the comment section, please.
Now, I would suggest all the diabetic patients to have those who have a CBG machine. In that, they should always maintain a diet and write those values regularly. Whenever they check that, it's a good habit. They should make it a habit.
Yes.
Whenever they should have a separate diary in which whenever they do the test, they should be writing it.
Yes. So I think it's clear. Prevention is better than cure.
Yeah.
Okay. So the next question coming up about antidepressants. Person taking antidepressant can be affected from mucormycosis.
Antidepressant patient, is not about the antidepressant. Depressed people have a high chance of
Exactly, sir.
infection because they're depressed. They don't eat properly. Sometimes they land up with bulimia nervosa. That they forget eating. They eat less. They sleep less. As a result, overall their immunity goes down because they are not getting proper nutrition, goes down, and due to that since the immunity goes down, we are coming back to the same equation. Find the reason for that low immunity. If you can find any clue that something that causes the immunity to plunge down, this mucormycosis will be hauling that person's body or anywhere in his system. High chances. So people on antidepressant will not, but people on antidepressant, because they are having depressive things, symptoms, and they are having the depressing complexities, and so they might land up with mucormycosis.
So
And also these people have been seen to say they're not very regular with the bath, they're not very much regular with the cleanliness or hygiene, and they land up with these kind of situations. Any next question?
yes.
I hope it's clear.
I hope the question is from COVID Basu. Yes, it's clear.
Yeah, COVID. Yeah, COVID.
Yeah, it's clear, sir. Okay, so that means the message is to be healthy and to be happy. Okay, so the next question is, okay, so after recovery from COVID, how much time does our body mostly take to regain its proper immunity power?
This is person specific. What COVID, people do. COVID can be symptomatic, asymptomatic. COVID can have myriad of symptoms. Some people have very critical symptoms, some people have moderate symptoms, and do not have symptoms at all. In serious symptoms, it also depends. So this is an abstract thing to say that how long it will take, but usually people take about 2 to 3 months. If I take in severely affected with COVID people in the lungs, especially the lungs consolidation has taken place, much of the lungs has been affected. It was a CT score, the CTSS score is around 20, 24, 20, 25 or 22, whatever it is, 20 and above. They will take longer time to recover. And some people also develop secondary issues like cerebral issues or certain psychological issues. It has been seen, these people are having. So it's very difficult to predict that how long it's going to be. It's not a cup of tea. You're going to have a cup of tea and say, okay, I need this much of sugar, or I don't need a sugar. So actually, it's something which is very dynamic.
Okay, so I think it's done. Are you satisfied with your answer, Ishita? Please write in the comment section. Yeah, thank you, sir. Okay, so the next question, sir, it asks that what is the rampant use of industrial oxygen enhances black fungus infection cases?
Well, industrial oxygen has nothing to do with the black fungus. Only thing is the industrial oxygen can be impure, and the purity factor is not there. Then it can put in certain toxic things into the body. And in case if it is very improper or impure, then it might contain certain fungus. And if it's been given to a COVID patient who's already immune status is down, so that person might land up with this mucormycosis. It all depends, what purity that industrial oxygen. Industrial oxygen is not very much pure in that sense. The sterility is not a big factor in that, because they need the oxygen or it is burned. So the sterilization factor is important. So in that case, the person can have fungal infection, bacterial infection, even bacterial pneumonitis, anything goes. It depends on what kind of product that he is using. But usually industrial oxygen is never used.
Okay. So the next question is
So the idea is that you are not going to do or take, or not for yourself, not for any patient, you are going to advise for something which is not advised. So why will you think of industrial oxygen? Why will you think of industrial oxygen? You might think of industrial nitrogen. You can think of many things, but only thing you have to follow the guidelines. It's not you who is going to decide. It is the central committee, it's the scientific board, international, national boards. They are going to decide how we are going to treat. It's not that we have to decide. We take the decisions what we treat. We have to only do and follow meticulously the protocols as laid by the government for any treatment, not only mucormycosis, for any treatment.
Okay, I think you are satisfied. So, okay, yeah. The next question coming up, sir, that what home precautions can we take after recovering from COVID to prevent mucormycosis? Or anyone, or any non-COVID patient, if it's of old age, what precautions should we take?
It's not. The question should be that which I can actually understand. What the person is trying to ask me is that if a patient has COVID and he's gone back home, so what are the precautions?
Yes.
First is hygiene. Hygiene should be clear. The air, the the room in which the person is staying should be well ventilated. He should be having his sleep properly, and all the lifestyle procedures should be as strict as possible, because you cannot be careless after post-COVID, because your body is already compromised, and you must give your body enough biorhythm, enough sleep to get back its energy back, or get its back its immunity, because during the sleep, body needs sleep, ATP, lots of cellular mechanisms and cells are also formed. So you have to allow that body to. So main thing hygiene, and that means humidity score should be around 30-40%, not more than that. The room humidity status, remember, this is very important. So always keep the room aerated.
Yes. Okay. I think Anagh, you got your answer.
Excuse me, sir. Excuse me, Sayantan. We have a question on our Facebook Live.
Yes.
By John Benjoy Paul, that can mucormycosis spread through air? Can mucormycosis spread through air, or does it take the route taken by the COVID virus to enter our body?
Yeah, actually, most of the fungal spores, they are actually usually not airborne. First, the good news is this: they are actually contact borne. It comes from the environment. Somehow it comes and touches your area and settles on your nose area, or your clothes, or your hands, and you touch, and it takes its entry to the airway. So first thing is this. Second is, as I told you in that slide in the presentation, that it cannot be communicated. It does not be transmitted from one person to other person. So it is not exactly airborne, it is actually contact borne.
Sir, we have another question.
Yes.
That are cigarette smokers or COPD patients more prone to mucormycosis?
Smokers are prone to mucormycosis, that's true, and COPD patients will be prone to it, but it's not of the proneness, but the risk mucormycosis is more enhanced in COPD patients, because the mortality rate with any lung disease in COPD patients is always high. So that is actually the main concept you have to understand. It's not the smoking thing, it's not the COPD thing, it's the disease itself that is going to be more fatal. Because a COPD patient, if at all contracts mucormycosis, will end up in trouble.
I think, Anagh, there is no more question from the Facebook Live, right?
No, Dada, there is no more questions.
Okay. Okay, so the last question we are coming up here, is mucormycosis curable disease in non-immunocompromised patient? If yes, then why and how mostly immunocompromised or COVID patients are leading deaths, causing epidemic in India? I think this is a contradictory question. Okay, fine.
First of all, mucormycosis is curable. I told you it's a dreaded disease,
Yes.
definitely, but it doesn't mean that you cannot cure it. There is the right timing is very important.
Yes.
Understanding the right timing of amphotericin B, which is with ICMR guidelines, tells that the timing of therapy is very important. Second, you have to diagnose. Diagnosing the thing is very important. Early detection is very important. So whenever you see a case, a suspicious case, always act prompt. Don't wait. Don't tell the patient, or don't make the patient go around the bush. That is very important. Are you getting it?
Yes, sir. I think, Anamika, your doubt is clear.
If not clear, you can ask me again.
Yes, you can write in the comment section. Okay, I hope there are no more questions. The doubts are almost solved and we have almost reached the end of our session. So, yes, so thank you everyone for being a good audience, and I will like to thank Sir for
Before
giving us a
before I end the thing,
Yes,
I want
sir.
to ask every one of you, if you can recollect the slide. What is the other name of mucormycosis? What is the other name which was known as before? I talked it in the slide. Can anybody of you tell me before I end the wonderful session that I had with all of you?
Yes, anyone?
The zygomycosis.
Absolutely correct. Sahu has tell the right answer.
Yes,
Thank you, Ritam. It's zygomycosis. Remember that.
Yes. Thank you, COVID. Your answer is also correct, zygomycosis. So thank you for being so much good listeners all, and for all your doubts. I hope they are cleared, and we have tried our best. And thank you, sir. You are such a busy person for giving us such a valuable time. All the doubt for solving our doubts.
It was an honor, and I really loved this session with all of you. Thank you very much.
Yes, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir. Welcome.
Okay, sir. So you want to give any message to us? Okay, guys, we are ending up with the meeting. Thank you all.